changes to heart failure management over the last few years, and there's been updates to guidelines, and there's been quite a few studies showing that newer agents are being used in heart failure. And I think a lot of our heart failure management tended to be, learned from what others were doing. And now I'm sure the GPs have seen there's little consistency in what we're doing. And these latest ESC guidelines have been published to try and make it a little bit more uniform and perhaps a little bit more comprehensive, so that most cardiologists should sort of be singing from the same hymn sheet. But you'll see it's not quite as simple as that as time goes on through this. So as an overview, hang on, I've messed this up already, haven't I? Overview, right. Am I there? Good, thanks, girls. Okay, so I'm going to talk about heart failure classification, physiology, treatment aims from a heart failure management point of view perspective. I want to run through some evidence. I know it's really boring looking at studies and Kaplan-Meier curves, but I've got a load of them. But I think it's important to understand really what's happened over the last few years with heart failure research, and how that has then influenced the latest guidelines. There's 2021 ESC guidelines for heart failure that I'll really be basing my advice on. A little bit about device therapy for heart failure, because that is really my specialist interest and still has a big role to play in the management of heart failure. And then how to diagnose heart failure, useful investigations, my slide. And I've also pulled out a few pertinent points from the guidelines. So let's start with the classification of heart failure. So you can classify the causes of heart failure due to the etiology. So basically coronary heart disease or non-coronary heart disease, ischemic, non-ischemic, dilated cardiomyopathy, ischemic cardiomyopathy. You can classify it based on heart failure that's due to a rhythm disturbance, such as atrial fibrillation with a poorly controlled ventricular response rate. Or you can have people who have heart failure due to valvular heart disease, in particular aortic stenosis or significant mitral valve disease. Other classifications look at the time course of people with acute heart failure, people turning up at A&E at 3 in the morning with acute pulmonary edema, to those who have got a chronic, more indolent course with chronic compensated heart failure. And then there's more and more people classifying cardiomyopathies based on genetics. So you'll get people who have gene positive hypertrophic cardiomyopathy, ARVC, and so on. But although it's a poor predictor of outcome in heart failure, all of the studies, or most of the clinical studies at least, discriminate heart failure based on ejection fraction. So the classification of ejection fraction now is, oh, hang on, I've lost my slides from here. What have I done? Where have they gone? Let's try and get them back. Sorry about this. That break. Usually I just open it in PowerPoint and share the PowerPoint, but I never have any luck. Sorry about this, everyone. Okay. Apologies. Okay, so we're back to this. So the ESC divide up heart failure based on ejection fraction. So anything over 50% is said to be preserved ejection fraction. Anything below 40% is reduced ejection fraction. And then they have this heart failure with mildly reduced ejection fraction group. So essentially, you can have heart failure with any ejection fraction. So a bit about the etiology of heart failure. This is sort of obviously a very simplified overview, but you've got two parts to this. You've got one side, which is essentially the kidney, where you have overactivation of your neurohormonal pathways, causing sodium, water retention, increasing volume to try and push the heart up the Starling curve, but that becomes a maladaptive response, increases preload, causes myocardial damage, and then you end up with poor left ventricular function, reduced cardiac output. And the other side, where you have mainly overdrive of sympathetic pathways causing vasoconstriction, hypertrophy, fibrosis, apoptosis, leading to increased afterload and having the same then effect on the heart, myocardial injury, poor left ventricular function, reduced cardiac output, and so on. And the mainstays of treatment for heart failure are thus to try and break this cycle. So the neurohormonal pathways really, broadly speaking, are the three pathways where our current regime of tablets targets. So sympathetic activation, vasopressin, heart rate going too fast, high contractility, and this is then opposed by the beta blockers. You've got the renin-angiotensin system activation, which is causing increased sympathetic tone as well, but aldosterone, hypertrophy, fibrosis, and these are then blocked by ACE inhibitors, angiotensin receptor blockers, and mineralocorticoid receptor antagonists. And then you've got the last group, the natriuretic peptide effects. So these are the newer drug, the ARNI. So this is specifically Entresto. So this is an angiotensin receptor neprilysin inhibitor. So there's been a lot about the use of Entresto as an alternative to ACE and ARBs. The idea of Entresto is that this neprilysin, so it's a combination of a drug called sacubitril and valsartan, which is an ARB, and the sacubitril specifically acts on the enzyme that breaks down natriuretic peptides, so endogenous natriuretic peptides. So you basically promote that effect. In heart failure, you've got a huge number of natriuretic peptides, hence a high BMP, and the body becomes resistant to those. So what you have to do is stop the breakdown of them and let the levels go higher to have that effect again. And there's good evidence that Entresto is very effective, and that was in the last set of guidelines. So what happens with heart failure and the trajectory of heart failure? And I'm sure you've all seen this, and it's been sort of similar ones sort of plagiarized through NHS documents as well. But people present with a poor functional status with symptoms at point 1 here. You've got these arrows dropping down where people can suffer sudden cardiac death irrespective of their functional class. And then a plateau phase where people improve. So that's number 2, where people have improved and then subsequently, here we are. So subsequently improve, and then this part of the trajectory is the bit where we're trying to maintain people on good medical therapy for as long as possible. And this is where all the benefits are being gained, is getting people on the right therapy and holding them up here as long as we possibly can. Then, unfortunately, there is, of course, an inevitable decline where we have dips with decompensated heart failure, admissions to hospital, resurrected with increased diuretics and perhaps optimized medical therapy. And then you get to the end where the people are end of life, or there's a big arrow back here for the very few people that end up with transplantation or left ventricular assist devices, which I'll touch on later. The treatment aims are really to improve quality of care, reduce mortality, and reduce hospitalization. Heart failure as a condition has a huge economic burden on the NHS, and anything we can do to try and keep people out of hospital will benefit the NHS. And unfortunately, the burden of cardiology work in hospital now is heart failure. At least half the patients on the ward have heart failure related disease. So I want to touch on some of the newer studies that have influenced the guidelines and things that you may have noticed that are being prescribed now much more frequently than they were before. So the first study to consider is the DAPA-HF study. So this was a large randomized trial looking at the use of dapagliflozin in people with heart failure and reduced ejection fraction. Now, we know from studies using SGLT2 inhibitors in diabetes that there was a reduction in mortality in people using these drugs, and in particular, people with heart disease seemed to benefit the most. And that was the premise of this study, was to see whether actually randomizing people with or without diabetes to take dapagliflozin would improve outcome. So this study is a massive study, almost 5,000 people. And when you look back to the early heart failure studies of ACE inhibitors back in the 1980s, you'd have 300 or 400 people in a big study with 200 people in each arm. So it just shows now that all of these people, all new agents have to be trialed on people already on optimal medical therapy. And you'll see here on this slide, 94% of these people were on an ACE inhibitor, 96% on a beta blocker, and 71% on an MRA. So these are people on really good medical therapy. They had to still have symptoms, so NYHA class 2 to 4 heart failure, an ejection fraction less than 40%, so heart failure with a reduced ejection fraction according to the ESC criteria, and an elevated BNP. They excluded people with very poor renal function, hypotension, and type 1 diabetes. And I've done that right. So on this slide, this is the, here we go, Kaplan-Meier curves. So this was the primary outcome, was a composite of death from cardiovascular causes or hospitalization for heart failure, or an urgent visit resulting in urgent hospital visit resulting in IV therapy. I don't really like that part of the endpoint because the threshold for getting IV therapy in hospital varies very much country to country. So, and I can't remember the exact demographics of the DAPA population, but in the UK, you've got to be near death before you end up getting intravenous therapy. When, if you're insured in California, you probably only have to say you've coughed a couple of times and you get admitted and get intravenous therapy. So, but I mean, it's randomized. So both groups were subjected to the same thing. So you can see here, there's very early separation of these curves, and then they tend to stay fairly separate all the way along to 2 years. So this is a sustained benefit in the composite endpoint. So it's a very effective drug, and this is the first drug really since Entresto that's shown an improvement in outcome. The second study is a similar study, but this was using empagliflozin rather than dapagliflozin. So this is the Emperor reduced, it was called. Similar entry criteria, although they went for people with worse heart failure. So they tried to get people with a worse ejection fraction. So if we flick back a couple of slides, this lot had an ejection fraction of 31%. I think Emperor reduced was 27%. So you can see that this was a little bit of a worse group. The BNPs were a lot higher. They let you have an EGFR right down to 20, which is fairly impressive. And just to prove that the effect of dapagliflozin wasn't specific to dapagliflozin, it's actually a class effect. You can see the same thing, an early separation of the curves. This lot dropped off the hospital admission for intravenous therapy. So this was a proper composite endpoint of death or hospitalization. So fairly hard endpoint study. And similar separation of the curves, starts early and is still sustained at the end of follow-up. This is a very impressive study for both dapagliflozin for the DAPA and then Emperor reduced. The other look at the Emperor study was to look at the effect of SGLT2 inhibitors on renal function. And I mean, I've noticed in my own clinical practice that starting people on these medications sometimes results in quite a frightening reduction in renal function fairly early on, which then seems to plateau if you can stick it. And that was really mirrored in this study, where you can see this is the EGFR in the placebo group dropping off over time with heart failure, and in the empagliflozin group there was this dip that plateaued, and actually over time you end up with renal protective effects of these drugs, which is important, especially as a lot of our patients with heart failure are diabetic, and in both these studies around 50% of people had type 2 diabetes. The next study that I think is important is this Soloist study. So this was using sotagliflozin, which I'm not familiar with, and I'm not sure we use it in the UK. But it's a similar SGLT2 inhibitor. It's taken once a day, and they tried to use it to show that you could use it in an acutely unwell patient. So they had people with acute admissions to hospital and were starting the drug very early, either while in hospital or very early after discharge. So the mean age in the study was 69. So they were quite young people compared to, well, at least compared to my heart failure population. But they had severe left ventricular function. They had high BNPs. These were all type 2 diabetics actually in this group. So this didn't have the other two studies were both people without diabetes and people with type 2 diabetes. This study just had people with diabetes, and they followed them up for 16 months. And similar, this is quite impressive. Now, this is not the same sort of thing, but it's a primary efficacy endpoint of deaths from cardiovascular causes or hospitalizations and urgent visits. So there's an early separation, and it seems to be much more effective. And I think that's because we've chosen a much sicker group. So not only was it safe to give people SGLT2 inhibitors to people who are acutely unwell, it actually seems to benefit the sicker people more than it does stable people. So that was an important take-home message from that. The Pioneer study was similar, but this looked at BMP changes in Entresto versus just using enalapril. So this is an ACE inhibitor versus Entresto, which you remember was valsartan and sacubitril. This is the ARNI tablet that I mentioned earlier. So this was using them early. So the license initially for Entresto was people with chronic stable heart failure. And there's obviously a push to get people on Entresto early. And the previous guidelines said that we had to start people on an ACE inhibitor and then swap them over onto Entresto. But there's evidence now that going straight onto Entresto in somebody with decompensated heart failure is beneficial. So this was a simple study which just looked at changes in BMP in people admitted with acute decompensated heart failure. And this is the result. So you can see in both groups, starting treatment and giving people intravenous diuretics quickly reduced BMP, but it was much more significant in the Entresto group with a 46.7% reduction compared to a 25% reduction with enalapril. So this drug's twice as good as the enalapril at reducing your BMP, and we know BMP is an important prognostic marker in heart failure. So that's important. So what we've learned from these studies so far is that you can use SGLT2 inhibitors. They improve survival. They can be started early, and so can Entresto, which before could only be used in chronic heart failure. So the guidance had a number of concepts in it that were new. One was a nomenclature, oh my God, a name change for for heart failure in the mid-range. They had this mid-range thing before, and now it's become mildly reduced. There's a simplified algorithm, which I'll come to. There was additions to the algorithm according to phenotype, so I'll come on to that as well and explain what that means. The classification for heart failure included now acute heart failure, which was something that had been omitted before. There are updates on how to manage people with other comorbid conditions, which is really important because a lot of these studies really single out heart failure, especially in younger people, and where heart failure is the main problem, and they don't seem to have that much in the way of comorbidities, when actually in practice our population, especially in Warwickshire, is very elderly and have lots of other problems as well. So this is quite an important bit of it. There was an update on cardiomyopathies and genetic testing, which was really interesting, and for Europe it has some implications. In the UK, where genetic testing isn't that widely used, it doesn't really matter. The other bit was additions of quality indicators, early follow-up, MDTs, and rehab. And I'll touch on that again later, but there's guidelines really suggest that we should be following up our heart failure patients 2 weeks post-discharge. And at Warwick, we're trying very hard to achieve that. But you can imagine it's pretty hard. The pressure on outpatients at the minute is ridiculous, and trying to get people properly seen at 2 weeks is a real challenge that we're trying to meet. Um, MDT is something we've set up at Warwick, so we do have a heart failure MDT, and cardiac rehab for heart failure is tricky. It's not funded as it is for post MI cardiac rehabilitation, although there's a huge amount of evidence to support it, and I'll touch on to that later. So, how do we manage people with heart failure? So we've got two slides here to look at. So what we had before was an order of how to start tablets. You start people on an ACE inhibitor, you start people on a beta blocker. If they're still symptomatic, then you should give them an aldosterone antagonist. If they're still tachycardic, you could give them a vabradine, so on and so forth. And it was quite didactic and didn't always fit the patient. In this guideline, they've taken that out and they've just said management of patients with heart failure and reduced ejection fraction should be on these 4 pillars of heart failure management. So an ACE inhibitor or an ARNI, so this is the Entresto, a beta blocker, they should be on an MRA, so spironolactone or a pleuronone. They should be on one of those 2 SGLT2 inhibitors, dapagliflozin or empagliflozin, and of course you can use a loop diuretic for fluid retention. The important thing about the diuretics are important for symptoms, but there is no evidence that loop diuretics actually improve outcome. Clearly, when you're in pulmonary edema and laying in resus at 3 in the morning, a shot of furosemide saves the day. But in the longer term, loop diuretics are actually a bad thing. The higher dose of diuretic you're on, the more likely you are to die, which is the opposite for all of these tablets. So yes, you can use it for symptoms, but it has nothing to do with prognosis. So you get these people on your 4 tablets, and then you can make a decision about devices, and I'll come on to that. I've got a more detailed slide next, which sort of covers this better. But essentially, if you've got poor ejection fraction and left bundle branch block, you can have a cardiac resynchronization therapy, defibrillator or pacemaker, and then you get to the end of that, and if you've still got problems, then you can go on to therapies that haven't got a class 1 indication. So this is essentially your class 1 slide. Why haven't they put an order in for the tablets? Now I've actually asked this at a conference. Why didn't you do this? Because I thought it would be so much easier if you told us what we should do. Start this tablet, start that tablet, etc. And they said, well, not all people were being optimized. So in other words, someone could have heart failure and be started on an ACE inhibitor and do better, not feel too bad, and then not ever be started on the other tablets. And it's the combination, it's the cumulative effect of these tablets. As I pointed out earlier, all the people in that dapagliflozin study were already on an ACE inhibitor, a beta blocker, an MRA. So this is not necessarily an effect of dapagliflozin on its own or an ACE inhibitor on its own. We've got to think of this as essentially one therapy, but just made up of these 4 pillars. Patients become asymptomatic and don't want more pills, and I can understand that. And that is a problem because that leads on to the next point, is that you underestimate the risk of sudden cardiac death. And if you look back at that slide I had of the trajectory of heart failure, remember people can drop off their perch even when they're really asymptomatic and doing very well, not necessarily when they're at their dips and decompensated. And I'm sure we've all got patients we can think of that were doing very well, and then you find that they've died. They weren't the sick ones that were bouncing in and out of hospital. Initially, and I felt this as well, that perhaps people should all be on a decent dose of one tablet before you moved on to the next. If you look at studies for ACE inhibitors for example, ramipril in heart failure, most of the people in the study got up onto 10 milligrams of ramipril, but I don't see that many people with heart failure on 10 milligrams of ramipril. And should we be getting people up to 10 milligrams of ramipril and then starting the beta blocker and then starting the spironolactone? Do you use up all the blood pressure on one tablet and not, and then deny them another tablet? And there's been a few studies looking at this. None of them are very good, but I think the overall outcome is that you're better off on a bit of everything rather than just being on a high dose of one of them. So don't use up all your blood pressure on one tablet. That's been the good thing about the SGLT2 inhibitors is they have very little effect on blood pressure. They have a slight diuretic effect due to their mechanism of action, but they don't have much impact on blood pressure, and we know you can start them acutely. So it seems sensible that that's really the first one that you should try. So I hope this projects all right for you guys. But that was really the class 1 indications from the guidelines. So the things you had to do. This has the class 2 guidelines in it as well. So firstly, you've got your 4 pillars of heart failure management: ACE inhibitor, ARNI, beta blocker, MRA, and the SGLT2 inhibitors. And the recommendations, not from the ESC, but from a number of editorials commenting on it, is that we should be starting these drugs as quickly as we possibly can. So trying to start all 4 in 4 weeks. And we are trying to achieve that by obviously starting as many things as we can as an inpatient in hospital, which there's no evidence to say isn't a bad thing to do. And then seeing them again at 2 weeks, where the ones they're not on could be started. And then hopefully these people can then be picked up by our heart failure services in the community to keep trying to up titrate the doses to the maximum tolerated doses. The next bit was offloading fluids. So diuretics gets a little green box there. Yes, if you're overloaded, you need to have some diuretics. So that makes sense. Ideally, though, please go on at the beginning, and then as we up titrate these sort of disease modifying drugs, so to speak, we should be able to get people off diuretics. That should really be our aim, or at least off high dose diuretics. Cardiac devices to improve symptoms and reduce risk of sudden cardiac death. So I know I've arced on about people, dying suddenly from sudden cardiac death at any point along that trajectory, and that's where devices have a role. So there's a dual part to the cardiac devices. We've got devices such as cardiac resynchronization therapy, which aim to improve symptoms of heart failure, and there's some evidence that perhaps that also improves outcome and prognosis. And then you've got patients who have a risk of sudden cardiac death that can be ameliorated by having a defibrillator fitted, so that if they developed a life-threatening arrhythmia, then it could be dealt with quickly. So I'll touch on to the classification, the guidance, the NICE guidance for that in a moment. This is a slide about, well, this line you can see is mainly yellow. So these are class 2 recommendations. Firstly, if you've got atrial fibrillation, you should be anticoagulated. There's some good evidence for that, and we should do it. Atrial fibrillation and ablation procedures. There's really not much evidence for atrial fibrillation ablation procedures in heart failure at all. I rarely send people with heart failure to the electrophysiologist for an ablation. Most of the studies for AF ablation, even outside heart failure, haven't shown a benefit. So although a lot of people are on the waiting list for an AF ablation, the only benefit from an AF ablation is that it might improve your symptoms if you're symptomatic from your atrial fibrillation ablation. But if you're symptomatic from atrial fibrillation, there's no evidence that an AF ablation suddenly improves heart failure. It may do if you can't get control of your heart rate, but so it's a heart rate cardiomyopathy, not necessarily due to the atrial fibrillation. I'll touch on revascularization. I've got a slide now of a study that came out a couple of weeks ago, but essentially revascularization is a little bit controversial. There's some evidence if you've got poor left ventricular function that coronary artery bypass grafting can be beneficial if there was a large amount of so-called viability. So in other words, if the artery that there was an artery pretending an area of heart muscle which wasn't functioning but could function under stress, so it was still viable. In other words, if you revascularized it, that heart muscle would wake up and work. The catch is, of course, you've got to put someone with bad heart failure through coronary artery bypass grafting. So the thought was perhaps that doing everything percutaneously would be hugely beneficial. And I'll show you the slide, but it isn't. Um, the next bit there is about iron therapy. You'll probably see we're giving a lot more intravenous iron than we ever were before. I'm not sure it's intravenous iron that is really I mean, it was the study for intravenous iron was funded by a company that sold intravenous iron. So obviously intravenous iron works, but I'm sure it's any iron. It's not it's not any different whether it's in a tablet or whether it's intravenous. But obviously you can treat things a lot quicker and you can get people's iron levels up higher quickly giving it intravenously. And we've got a medical day case unit in Warwick where we put a lot of our patients through who are iron deficient and have heart failure. And I'm not sure I've actually seen people say they're a whole lot better after having their iron, but there's data there to support it, although it was only a couple of studies, hence it's only got a class 2 recommendation. The last bit here, mainly I wanted to focus on was the TAVI bit, but there are new technologies that are meaning that people with valvular heart disease, for example, can actually get sorted out without open heart surgery. And you've probably all got thousands of people on the books who have had TAVI done somewhere locally. We are really getting TAVI services across the West Midlands are really doing very well. Coventry have now got a very active service. Previously, all our patients were going to QE. QE still offer a great service. So having a trans-aortic valve implant for aortic stenosis is proving to be a bit of a boon. There are new technologies looking at mitral valve intervention percutaneously. I think it's not clear yet which patients really are those that are going to benefit, especially in the heart failure group. This is an emerging technology. A few centers are doing it. I think that's a bit more of a watch this space, really. Then you get to the other bit there was about avabradine and other tablets that you can use, thiazide diuretics, hydralazine. If you can't have an ACE inhibitor, you can have an ARB. There's a lot of talk about transplant still. We have an active transplant center in Birmingham, one of the biggest in the country. A great service is provided there. The two cardiologists that run it are both really good guys. They do an amazing job, but transplant is limited by donors. And when transplant really took off, cars didn't have seatbelts, and now cars have got seatbelts. We don't have as many hearts, and heart transplantation has really become very static. So I can't really see heart transplantation going any further, and mechanical support is really taking over. The mean survival after a transplant in the UK is about 10 years. We've now got people with left ventricular assist devices, specifically the HeartMate device, which have now surviving well beyond 10 years. The problems are obviously due to clotting. So these have a mechanical impeller. So you have to be anticoagulated, and clots can form in them, and obviously embolize and cause stroke and so on. So that can be a problem. The other thing is they're not, although they're implanted, there's a drive line out to a control box, and drive line infections are a big problem and have limited things. But at some point, we're going to crack the technology. The technology is moving on very, very fast and will overtake. The issue with both are very expensive technologies. Transplant isn't that expensive. These devices end up being very, very expensive. And I think an LVAD is about £150,000. At the minute, you have to be on the transplant waiting list to have funding for an LVAD. So these are funded for a bridge to transplant. So unless you're a viable transplant candidate, you're not going to get an LVAD. And a lot more people, though, are having LVADs fitted than people who get transplants. And in other European countries, people are really now using mechanical support devices as so-called destination therapy. This is not a bridge to transplant. This is now a destination. And I've got a couple of patients that I follow up in Warwick with LVADs, and they do very, very well. Cardiac rehabilitation. I mean, I touched on this earlier. Cardiac rehabilitation for heart failure is almost as good as an ACE inhibitor in some of the rehabilitation studies. It's very, very impressive. The problem is nobody sells it, and it's very, very expensive to deliver. We have set up a small heart failure rehab pilot study at Mighton Hospice in Warwick, which was going quite well, but we've had problems with ongoing funding. So at the minute, it's stopped. But it is really useful, and I need to try and think of a way of how I can fund heart failure rehabilitation. I hopefully these guidelines gradually seep through, and one day it may be actually funded. But I think it's a really important thing that we overlook. The heart failure MDT is really important as well, and that's been highlighted in these guidelines. So a heart failure MDT is something that has lots of not just different cardiologists, but different specialties involved. It's particularly palliative care. I think that's really important. It's part of heart failure management that we don't necessarily give the appropriate attention to. It's very important as well to have somebody, these MDTs, who's good at cardiac imaging. It's really important to have a renal physician. It's really important to have somebody who understands cardiac devices, because of course this comes into this. If someone's end of life, when do we switch off defibs? All of those sorts of conversations that have to be had. And also, just managing, supporting the heart failure nurses in the community, because we've, we've in Warwick, I think we've got 6 community heart failure nurses now. Dr. Qureshi heads up the heart failure MDT there. So she's offering support to those nurses for the difficult patients. She has also some virtual slots that she does with GPs where they discuss patients and so on and so forth. So I think this is really a way forward when it comes to heart failure management, because there's a huge burden of work here that needs to be dealt with, and dealing with it efficiently like that means that most people will get better treatment. I popped this slide in just to show you that I actually did look at the slides for this recently, because this was only published last month. But this was a really good study that I really had some hope in, that was percutaneous revascularization for ischemic LVSD. And I thought maybe the problem with the previous studies with bypass surgery were that obviously putting people through bypass operations with heart failure was a bit dicey, and were they actually picking out the really sick ones that would benefit from it, because they had quite strict exclusion criteria, because obviously they didn't want to have a huge mortality from it and everyone get put off coronary artery bypass grafting altogether. So PCI might be the way forward. You can do an angioplasty on somebody who has a fairly poor heart quite safely, but unfortunately, it didn't work. There was same mortality in both groups, well, nothing clinically or statistically significant, which is a real shame. But it does mean that we don't really need to worry about looking at heart arteries in people who are quite poorly and aren't a candidate for bypass grafting. So it gives us that knowledge anyway. Now, this slide is very busy, and this was proposed by the ESC, and this is basically how to up-titrate drugs based on the patient's phenotype. So whether you've got a high heart rate, whether you've got poor renal function, whether you've got atrial fibrillation, whether you've got no blood pressure, which drug should you start first? And it's sort of logical. If you've got no blood pressure, then start SGLT2 inhibitors first. If you've got a high heart rate, then you can start beta blockers. If you've got a low heart rate, then beta blockers are lower down the list. If you've got high blood pressure, then get on things that help blood pressure. If you've got a CKD, then use the ARNIs last and up titrate the things that don't affect your kidneys, etc., etc. It's a bit messy and it doesn't really work. I've tried using it, and I guess it gives you a bit of guidance and it shows a way of doing this. We want to get all the patients on those 4 pillars of heart failure, but then this is a bit of a guide as to how to up titrate each of those things. So I wanted to touch on this. This is the risk of sudden death in heart failure. And I'm interested in this because being a device doctor and learning to put defibrillators in, I was doing that back based on data from here back in the late 90s, early thousands, where the first the first ICD studies came out in people on fairly early heart failure management. And back then, there was a huge benefit from having an implantable cardioverter defibrillator. But as time's gone on, you can see in all of these big studies. So these are all big heart failure studies. Paradigm was the Entresto one. So all of these things, you can see over time that actually heart failure mortality is dropping off. So is there still a benefit from having defibrillators fitted? And there's still ongoing studies looking at that. Obviously, no manufacturer of a defibrillator is now going to do a study to see if their defibrillator is still useful. So I think these things are set in stone and will continue to be used. But it shows that we do need to be mindful of this, and people's risk of sudden cardiac death is actually improving. This is the NICE criteria for a primary prevention defibrillator, and this has been the same now for about 7 years. I think COVID may have put a bit of a stop to it being updated. So it's due to be updated, and I think it may end up being a bit more like the European guidelines, which are slightly different. But this is what's happening here at the minute. So to have a defibrillator, you need to have heart failure, but you only have to have class 1 heart failure. But you have to have, this is in people with severe left ventricular function, and for NICE that is less than 35%, not less than 40%. And if you've got an EF less than 35%, you qualify for a defibrillator. Now, not everybody with an ejection fraction less than 35% gets a defibrillator. It clearly needs to be clinically appropriate. And this first group here with a narrow QRS is a very low risk group, and you have to be a little bit careful because the risk of a defibrillator is significant. The risk of inappropriate shocks, the psychological damage that can cause if you get a shock, driving and the DVLA can be a right pain. There's lots of reasons you might not want a defibrillator. But in the other groups where you start getting broad QRS, especially broad QRS with a proper left bundle branch block, then you are at a much higher risk statistically, and you definitely do benefit from an ICD. If you've got symptoms of heart failure and a broad QRS, then you also benefit from having cardiac resynchronization therapies. This is where we have a lead pacing the left ventricle as well as the right ventricle. You can see in class 4 heart failure, these are people who end stage heart failure. There may still be a benefit for cardiac resynchronization therapy pacemaker to improve symptoms, but we wouldn't recommend a defibrillator. Like all guidelines, there's no age mentioned in these guidelines, and this is a bit I find very difficult to manage because we have most of our heart failure population are well into their 80s, and the mean age of death for a man in Warwickshire, I think when I last looked, was 85 or something. And then you're going to offer this guy a defibrillator because you think it might make him live longer. All seems a bit silly. So I'm very selective in my elderly population, especially the over 80s, as to who should have a defibrillator. But we can give cardiac resynchronization therapy pacemakers out willy-nilly. It's a fairly simple, straightforward procedure, and if it improves someone's symptoms, whether you're 60 or 90, then you should have it. I can see there's a question about rehabilitation. Why is it expensive? You need a venue, you need to staff it, you need someone to organize it. So it ends up like cardiac rehabilitation, where you need an exercise physiologist, you need some trained nurses, you probably need a physiotherapist, and you need a gym to deliver it in. We've been lucky at Warwick, we've been allowed to use a couple of private gyms. And so some people give us some space to do it in, but it's funding the staff. So that's the problem, and trying to get staff at the minute in the NHS is a disaster. I had a look today at Warwick Hospital, where 187 whole-time equivalent nurses down. So there's no way we're going to get nurses to do this. So I think that's the problem, and it may look at how we deliver it. I mean, there's lots of online programs and other ways that it can be delivered, but none seem to be as effective as actually face-to-face contact. And getting some of our older population, you must have all come across it, trying to do, phone, video consults with elderly people and technology doesn't work. So that's what's expensive, and it's a resource that at the minute we're focusing on where most of the data is, and that's for ischemic heart disease. But hopefully we'll get funding, and if we get funding, then we can try and recruit people into it. A little bit here about heart failure preserved ejection fraction. So this is I've cut pasted this out of the ESC guidelines, and I didn't go to this conference. I was going to say I went to it. I didn't. I watched it on Teams, but this was last year's ESC, so it was quite funny. These new heart failure guidelines were published with this saying no treatment has been shown to reduce morbidity, mortality, and heart failure preserved ejection fraction. And then 3 hours later, these guys came out with this study, that word. Yeah, this Emperor Preserve study. So this was a follow-on from the empagliflozin group. So but this is their study with people with an ejection fraction greater than 40%. So essentially, this is the first study that has shown a survival benefit in people with heart failure and preserved ejection fraction. So there's been loads of studies looking at avabradine, Entresto, every drug virtually that we've tried in heart failure reduced ejection fraction has been tried in heart failure preserved ejection fraction, and we've never won. And I think this is an interesting study, is that in that they were very selective about who they took. They excluded people who had acute decompensation. They excluded people who had bad kidneys. They excluded people that had had anything happen to them in the last few months. They were very, very selective. I did some work on this when I was doing my PhD. I actually published a paper called Death and Dying in Heart Failure with Preserved Ejection Fraction. And the reason the studies fail is that everybody dies in the end. And people with heart failure preserved ejection fraction are old. And if you go and randomize a load of 85-year-olds to a treatment, a lot of them die, whatever you do. So that was the problem. And when you looked at the causes of death, it wasn't cardiovascular death. People with heart failure preserved ejection fraction died from renal failure. They died from stroke. They died from all other causes. It wasn't necessarily heart failure. And I think this is what's interesting about the empagliflozin study, is that, maybe this does improve people's renal function. It does do something to hold things together a bit longer. And this is quite interesting. So this is like data out to 3 years, but you will note, I'll flick back to this slide, the mean age was 72. So if you look at the heart, and 56% were men, so a lot less men than in the other studies. This is because heart failure preserved ejection fraction is typically a disease of hypertensive old ladies. So this is quite interesting. So it's important because this is the only treatment we've got, and you'll find us putting loads of people on empagliflozin for heart failure and preserved ejection fraction.
There's another question for you, Dr. Beadle.
DAPA 10. I can't remember the dose of empagliflozin. It's whatever the dose is, 20, isn't it? Is it 10 or maybe it's 10 as well? It's the same dose. I'll Google it and I'll tell you now. But it's dapagliflozin's 10 for sure, and I tend to use DAPA everywhere other than the heart failure preserved ejection fraction group. This is the problem with electronic prescribing, isn't it? Every time you type it in, it just fills in the dose for you. So I'll have to. Even the Nuffield have taken the BNFs out. Well, we've taken all the BNFs out of the room, and you have to do it on your phone, and it's really. Anyway, how to diagnose heart failure. So heart failure remains a clinical diagnosis. There is no test that diagnoses heart failure for you. First line investigation. So this was my slide until I found the slide from the ESC. So you need to do an ECG. You need some bloods, including BMP. It's a fantastic blood test, very useful. Thyroid function is also useful. The echocardiogram is of course useful, and if you've got that available in the community, brilliant. Then so a lot of patients that, especially by the time we see them in clinic with our huge waiting list, have already had an echocardiogram undertaken in the community, and they're brilliant. I think we overlook the chest X-ray too much. It can be still a really, really useful test. And what to do if you're overloaded, start a diuretic, and then you can start what you want. But the idea is we want to be on those 4 pillars. So an ACE or DAPA is really where we'd start our treatment. The slide from the ESC is sort of similar, but it's more colorful. But essentially, it says, you know, what's your risk of it? Is your BMP high? If your BMP is really high, then you go on and have an echo. If your BMP is not, then it's not heart failure. And if you've got an echo that's got lots of abnormalities, then you're right. And if you've got an echo that showed that your BMP was high, but your echo is normal, then heart failure is unlikely. That's a bit tricky because it's sometimes hard to diagnose heart failure, preserved ejection fraction. It says in the guidelines you should go on and look for signs of diastolic impairment, and that all gets a little bit tricky and a bit subjective. But anyway, and then it breaks down, you know, which heart failure you've got and how to meet it. And these were all class 1 recommendations. So, Mel's kindly looked up empagliflozin, and it's 10 milligrams as well. So there you go, DAPA 10 and empagliflozin 10 milligrams. So that's it. That's what all I really wanted to update everybody on, the new guidelines, the data to support them. Is there any other questions from anybody that you can either pipe up or put in the chat, whatever you would like to do? I'm happy to answer anything. How do I manage diastolic impairment, diastolic failure? So at the minute, it's treating, firstly, treating risk factors. So make sure you've got good diabetic control, make sure you've got good control of someone's hypertension, and it doesn't really matter what medication you use to control hypertension. People love amlodipine, but it causes edema in your ankles, and that confuses things a bit. So whatever you use, ACE inhibitors fine, and then now empagliflozin and diuretics. So our letters used to say this person's got heart failure, preserved ejection fraction, treat them with diuretics. Now it's treat them with empagliflozin and diuretics.
What are you doing, Amaya?
Hello. Someone speak. No.
Are there any further questions?
Stunned silence.
Here we go. Here's another one.
Yeah. Are we able to start the 4 pillars in primary care? Yes, I think you can. I guess it depends on everybody's. Yeah, and it's super long at Warwick and Coventry. Yes, I think you should. I mean, I don't think we should be scared about starting these tablets. It's been proven to be safe. I'd recommend, though, that if you start them, then you need some sort of system that they can get some bloods done in a couple of weeks' time to make sure we don't poison anybody. But we've been doing this. I've been checking everyone's bloods, and I do it diligently, especially the ones I see privately, because I have to see the bloods myself, and I've not caused a problem doing it. So, and traditionally for heart failure, we've up titrated ACE and beta blocker initially. Will DAPA replace beta blocker as a second line after? No. So this is what I'm trying to say. There is no second line thing anymore. All drugs should be started. So you need to be on Entresto. You need to be on a beta blocker. You need to be on dapagliflozin, and you need to be on an AR. You need to be on an MRA, spironolactone, or a pleuronone. So you need to get on all 4 before you start up titrating. So, and that's really what I'm trying to get at with this, is that it's not a matter of up titrating one and then adding in another. You might up titrate one tablet before another, depending on the phenotype, which was that slide with all the circles in. So if you've got someone who's really tachycardic and you want to try to get their heart rate down, then up titrate their beta blocker first. But the idea is to try and get them on all 4 as soon as you can.
Did you answer the question, why do we treat diastolic heart failure?
Oh, why do we treat it? Because people get really sick and die from it. Why do we treat it? Well, it should be treated the same as heart failure, whatever the cause. So, I mean, diastolic heart failure, just because I mean, it doesn't really matter if it's diastolic or systolic heart failure. The outcome is the same. You will end up with congestion, breathlessness, and symptoms. So I guess we're doing it to improve people's symptoms. And now we've got that Emperor Reserve study. We know that we can actually improve outcome as well. So we're not just improving people's symptoms. We may actually make people live longer.
There's another question just come in.
Okay, Dapper,
Dapper,
Entresto,
yeah.
still specialist advised in the formulary. Is this likely to change? I'd love it to change. There's so many things that, I mean, in Entresto, it's specialist advised, but you don't need an APC form anymore for us. Yeah, I hope it's going to be changed. There's lots of lobbying being done, and I think at the minute, especially with a long waiting list to see specialists, it's tricky, and it would be better if it could be started in primary care. Although then they're shifting a burden of care across to primary care, and it gets complicated. I think it will change, especially for dapagliflozin because it's being used so much for diabetes, and a lot of GPs have started it because they've got type 2 diabetes, and you think they've got heart failure, then it's a no-brainer. I think Entresto will change, and I think it's cost on these drugs, I think, which drives this more really than safety. Look at warfarin. Everyone could prescribe warfarin. Every GP was studying people on warfarin, and all of a sudden, a safe alternative came out with a single daily dose, and all of a sudden, we have to fill in forms and work out a Hasbled score. I mean, it's wild. So I think it's probably money, and I think what will make them not specialist advisors when they become cheap in a few years' time. Is there an EGFR? Yeah, I don't start below 30 mils per minute per 1.73 meters squared, whatever it is. So below 30, I hold off. I can see the studies say you can use it right down to 20. I'm a bit cautious, especially when you're starting all four at once. If you're stable and you've up-titrated the other drugs, and you've still got an EGFR around 25 or something, then I have started it. But at the beginning, I'd only start it if it's over 30. But that's just me. That's not in the guidelines. That's because I'm probably a little bit still nervous with them.
Are there any more questions, ladies and gents? If there aren't, then I would like to thank you all for attending, and thank you very much, Dr. Beadle, for giving up your time for us this evening. As I said at the beginning, if you wouldn't mind completing the survey and sending it back to us, that will be great, and I will make sure that you get the slides. Our next lecture, I will send an invitation out to you in the next few days, will be about autism, and I think it's the 7th of December, but I will send an invitation out to you. So if there are no more questions, thank you very much and have a good rest of the evening.
Thank you, everyone.
Thank you.
Thank you.